So, in this video, we're going to talk about overlapping symptoms and differential diagnoses. And this is something that's been requested because so often there are so many diagnoses that share similar symptoms. And oftentimes, we might look at one symptom and say, well, does it fit this diagnosis or this one or this one or this one? And that's what we call differential. We have multiple things in the mix, and we're just trying to sort out the best answer. So imagine sitting with a client who shares that they've been feeling tired all the time, struggling to focus, and snapping at loved ones. On the surface, it sounds like classic depression, right? But as you start asking more questions, things get murkier. The client mentions nightmares and flashbacks of a traumatic car accident years ago. And now you're considering PTSD. Then they casually add that they've always had trouble staying organized and remembering things. Could it be ADHD? This is where the importance of differential diagnosis becomes clear. Differential diagnosis is like being a detective, piecing together clues to figure out what's really going on. It matters because it determines how we help our clients. Imagine misdiagnosing ADHD as anxiety. A client might end up with a treatment plan focusing on calming techniques when all they really need is help with executive functioning or even medication. And it's not just about naming a condition, it's about giving clients the best tools for their specific needs. Once I worked with a client who came to therapy just convinced that they had depression. They felt exhausted, unmotivated, overwhelmed. And when we dug deeper, they talked about racing thoughts, impulsive decisions, and periods of extreme energy. And it turns out they had bipolar disorder. Treating them for just depression wouldn't have addressed the full picture, and it could have made things worse. Getting the diagnosis right allowed us to put together a plan that truly helped. Another reason differential diagnosis is so important is that symptoms often overlap, but their causes might be very different. Take difficulty concentrating. It's a hallmark of ADHD, but it also shows up in anxiety, trauma, and even medical issues like hypothyroid. Without looking at the bigger picture, we might miss the underlying causes that need attention. For example, symptoms of depression like sadness or fatigue might fit criteria for depressive disorder, but they could also be better explained by trauma, an adjustment disorder, anxiety, bipolar disorder, or even substance use. And that's why understanding when symptoms reach the threshold for a diagnosis, it's so important. Just because somebody feels depressed doesn't mean that they meet criteria for depression or a depressive disorder or that the depression is the main issue causing their distress. A question I often hear from students is, how do we know when sadness or another symptom is part of a larger diagnosis? So hopefully this video will help you build clarity around how to look for clues, what questions to ask, and when to dig deeper. Because ultimately differential diagnosis isn't just a technical step, it's an act of care. It's saying, I see you, I'm committed to understanding your unique story. And that's what makes therapy effective, ethical, and meaningful. Each client deserves that kind of attention. So, the purpose of this video is to help counselors and students deepen their understanding of differential diagnosis and the complexities that overlap symptoms in the DSM. By exploring key examples and practical strategies, the video aims to equip the viewers with the tools to ask the right questions, look for critical clues, and provide accurate, compassionate care tailored to each client's unique experience. The differential diagnosis is the process of systematically distinguishing between two or more conditions that share similar symptoms to identify the most accurate diagnosis. So let's step outside of mental health for a moment and think about physical health. One of the most common differentials people encounter is deciding, is it a cold, is it a flu, or is it COVID? They're all viral infections. And while someone might say sick is sick, it'll pass, proper treatment for each can vary significantly. For instance, hydration and rest might be enough for a cold, but antivirals can make a big difference for the flu and COVID. And COVID might even warrant some more specific interventions. So, diagnosis in this case doesn't just provide clarity, it guides treatment and ensures the best path towards recovery. So, how important is diagnosis to you? Maybe you value knowing exactly what's going on both in physical health and mental health. If so, this video is for you. Here we're grabbing the DSM and digging into the process of figuring it out. And for those looking into a more non pathologizing lens, just stay tuned. I'll make future videos exploring that perspective. But for now, let's dive into why diagnosis matters and how counselors can use it effectively. Accurate diagnosis is critical in mental health counseling because symptoms like fatigue, difficulty concentrating, or emotional dysregulation often overlap across different disorders. Without clear differentiation, clients may receive treatments that miss the mark, prolonging distress or even exacerbating their struggles. For example, consider a client who presents with symptoms of low energy and hopelessness. These could point to major depressive disorder, but what if they also report a history of periods of high energy and impulsivity? In that case, you might be looking at bipolar disorder. Diagnosing one without considering the other could lead to inappropriate or even harmful treatment. And this is where the DSM-5 TR and the ICD-11 become essential tools. The DSM provides detailed descriptions of symptoms, diagnostic criteria, and cultural considerations, making it a cornerstone for mental health professionals in North America. Meanwhile, the ICD offers a broader, internationally standardized framework with an emphasis on public health. Together, these resources guide counselors in assessing symptom severity, duration, and context to arrive at the most accurate diagnosis. For instance, the DSM outlines criteria to distinguish between depressive symptoms and major depressive disorder and those occurring as part of bipolar disorder, particularly noting the presence of manic or hypomanic episodes. Similarly, the ICD emphasizes how cultural and environmental factors may shape symptom expression, which influence how counselors approach assessments. These tools also encourage consideration of comorbidities, developmental trajectories, and situational factors, ensuring that counselors evaluate the client holistically rather than focusing solely on isolated symptoms. So instead of going diagnosis by diagnosis like the DSM does, let's focus on common symptoms and talk about the related diagnoses. So, starting with fatigue and sleep issues, disturbances here occur across post traumatic stress disorder, major depressive disorder, generalized anxiety disorder, and ADHD or attention deficit hyperactivity disorder, and substance use disorders, among others. In PTSD, sleep issues are typically driven by hyperarousal or nightmares, resulting in fragmented and non restorative sleep. Major depressive disorder, on the other hand, often features hypersomnia or insomnia linked to a lack of energy and pervasive sadness. In generalized anxiety disorder, difficulty falling or staying asleep stems from chronic worry or an overactive mind at night. ADHD sleep disturbances are usually related to trouble regulating activity levels or delayed sleep phase. In substance use disorders, sleep problems may arise from withdrawal effects, stimulant use, or substance related disruptions in the sleep cycle. For example, someone withdrawing from alcohol may experience insomnia and vivid dreams, while stimulant use often leads to sleep deprivation followed by a crash of exhaustion. Counselors must differentiate between the root causes to address the underlying issue. Difficulty concentrating often appears in ADHD, major depressive disorder, generalized anxiety disorder, and substance use disorders. But again, the reasons differ. ADHD related inattention is consistent across time and settings, stemming from neurodevelopmental challenges in focus and in executive functioning. Major depressive disorder concentration issues often manifest as a cognitive fog linked to rumination and slowed processing. In generalized anxiety disorder, concentration difficulties arise due to preoccupation with worry or anxiety. Substance use disorders can mimic or exacerbate concentration problems, particularly during periods of substance use or withdrawal. For example, opioid use might impair cognitive functioning, while stimulant withdrawal may leave clients feeling mentally sluggish and unfocused. Asking about onset, duration, and context of concentration problems is crucial in determining the primary diagnosis. And moving on to emotional dysregulation, borderline personality disorder, bipolar disorder, PTSD, and substance use disorders often feature emotional dysregulation. In borderline personality disorder, emotional instability is typically reactive to interpersonal triggers marked by rapid mood shifts. Bipolar disorder features mood dysregulation during manic, hypomanic, or depressive episodes, with impulsivity and grandiosity during highs and hopelessness during lows. SD, emotional dysregulation, is often linked to trauma, with sudden outbursts of anger or emotional numbing tied to triggers. In substance use disorders, dysregulation can result from substance induced mood changes or attempts to self regulate emotions through substance use. Can also happen during withdrawal periods. So, again, for instance, alcohol may initially dampen distress, but worsen emotional instability over time. Differentiating the source of dysregulation requires understanding the broader clinical picture. Impulsivity is common in ADHD, bipolar disorder, borderline personality disorder, and substance use disorders. ADHD impulsivity is driven by difficulties delaying gratification or regulating behavior, appearing consistently across settings. Bipolar disorder related impulsivity urges primarily during manic episodes, characterized by high risk behaviors like excessive spending or substance use. Borderline personality disorder impulsivity is often emotion driven, with behaviors like self harm or substance misuse tied to intense feelings of abandonment or anger. Substance use disorder related impulsivity may stem from cravings, withdrawal states, or substance induced impairments in judgment. For example, somebody using stimulants may engage in reckless or compulsive behaviors. Exploring patterns of impulsivity and their triggers helps to clarify the diagnosis. Again, we're looking for that root cause. What's going on underneath the symptom? And the last one that we have on this slide is social withdrawal and avoidance. We're going to talk a little bit more about that on the next slide when we're talking about paranoia, hallucinations, and schizophrenia spectrum diagnoses. But for right now, we're going to stay attached to the main ones. So, social withdrawal and avoidance are seen in post traumatic stress disorder, major depressive disorder, autism spectrum disorder, and substance use disorders, though the motivations differ. PTSD avoidance is trauma specific, with clients steering clear of reminders that might trigger distress. In major depressive disorder, withdrawal stems from feelings of hopelessness, fatigue, or lack of motivation. Autism related withdrawal reflects on a preference for solitude or difficulties with social communication rather than emotional avoidance. Substance use disorder, social withdrawal often occurs to shame, stigma, or the desire to conceal substance use. So, a client with alcohol dependence might avoid family gatherings to hide their drinking. Understanding the why behind social withdrawal is key to the accurate assessment. So we have a lot of overlapping symptoms, and this set of diagnoses often feels deeply connected. And it can be challenging to differentiate or pull out the symptoms from the diagnoses. So that's why it just deserves its own slide. So, positive symptoms like hallucinations and delusions, and the negative symptoms like emotional flattening and withdrawal overlap in ways that can get really confusing, and many conditions share elements of psychosis, withdrawal, and impaired thinking. So, understanding these disorders is especially important because their presentations can look really similar, but the underlying causes and therefore the treatments can be vastly different. So, for many counselors and students, these diagnoses are tricky because they exist on a spectrum of psychosis, mood, and personality. So, for example, psychotic symptoms can appear independently in schizophrenia or alongside mood episodes in schizoaffective disorder or mood disorders with psychotic features. Social withdrawal can be rooted in fear of judgment, as in schizotypal personality disorder, or reflect a lack of interest in relationships, as in schizoid personality disorder. And substance use complicates the picture further, as substance induced psychosis can mimic primary psychotic disorders but resolves with sobriety. So here's a breakdown of how the conditions are different. Starting with schizophrenia, we've got persistent hallucinations, delusions, and disorganized thinking or behavior. Social withdrawal often stems from paranoia or difficulty distinguishing reality, along with negative symptoms like apathy. Symptoms must persist for at least 6 months and significantly impair functioning. Delusional disorder is defined by fixed, non bizarre delusions. So, believing a partner is unfaithful without evidence would be an example. Functioning outside the delusion is typically preserved, and hallucinations or disorganized thinking are rare. So it's really, we're just looking at the delusional component. For schizoaffective disorder, this combines features of schizophrenia like hallucinations and delusions with mood disorder symptoms like depression or mania. Psychosis occurs independently from mood symptoms for at least 2 weeks, and that differentiates from mood disorders with psychotic features, where the psychosis only occurs in the mood episode. So, the question here of schizoaffective versus mood disorder with psychotic feature is the psychosis occurring with the mood or without the mood? And again, mood disorders with psychotic features is the psychotic symptoms such as hallucinations or delusions occur exclusively during mood episodes. So major depressive or manic episodes, usually. Schizoid personality disorder is characterized by a fundamental lack of desire for relationships or emotional connection. So unlike schizophrenia, individuals with schizoid personality disorder do not experience hallucinations or delusions. Schizotypal personality disorder features paranoia, social withdrawal, and eccentric thought patterns like magical thinking or odd beliefs. Psychotic like symptoms are mild and transient, often emerging under stress. And throwing in substance use disorders here. So, substance induced psychosis presents with hallucinations or delusions, or it can during intoxication or withdrawal. So, oftentimes you might hear about paranoia from methamphetamine use or hallucinations during alcohol withdrawal. Symptoms resolve with abstinence, distinguishing them from a primary psychotic disorder. So, the farther an individual gets away from the substance use, the less the psychosis occurs. So, we need to think about some key considerations for differential diagnosis and its duration and context. Symptoms linked to substance use typically resolve within weeks, while those in schizophrenia or schizoaffective disorder persist long term. We need to look at impairment level. So, schizophrenia and schizoaffective disorder severely impair functioning, whereas schizoid and schizotypal traits may allow stable functioning in solitary or structured environments. And we also always want to look at cultural considerations. Religious or cultural beliefs might resemble delusions, but are normal within their context. Careful evaluation of onset, duration, and context is critical. For example, a client presenting with paranoia and hallucinations might initially appear to have schizophrenia. However, closer assessment might reveal substance use or schizotypal traits as the primary cause. Understanding these nuances not only improves diagnostic accuracy, but also ensures tailored interventions that address the client's specific needs. And this thoughtful process is what transforms confusion into clarity in clinical practice. Asking the right questions is one of the most important parts of understanding what a client is experiencing. It's like following a trail of breadcrumbs to get to the heart of what's really going on. One of the first steps is identifying the client's primary symptoms. For example, if somebody says they feel sad or they've lost interest in things they used to enjoy, you might ask, well, what do you think triggers those feelings? Are they tied to certain situations or people? A client with major depressive disorder might describe a constant heavy sadness that isn't tied to specific events, while somebody with PTSD might share that their sadness is linked to reminders of past trauma. Questions like, do your energy levels stay low all day or do they go up and down? Can help differentiate between depressive fatigue and something more episodic like bipolar disorder or even ADHD, where bursts of energy might alternate with exhaustion. Another important area to explore is the onset of symptoms and their context. A simple question like, when did this all start, can open up a lot of useful information. For instance, if a client reports that they've been hearing voices, but it started after a period of heavy substance use, that might point towards substance induced psychosis rather than schizophrenia. On the other hand, if they say that the voices began years ago without any substance involvement and has persisted ever since, it could suggest a primary psychotic disorder. Questions like, have these feelings been constant or do they come and go, can help narrow things down. Consistent symptoms might indicate major depressive disorder, generalized anxiety disorder, while mood swings or episodic symptoms could point to bipolar disorder or even schizoaffective disorder. It's also crucial to consider whether there might be multiple issues at play. Many clients come in with overlapping symptoms, so it's worth asking questions about things like substance use, past trauma, coping strategies. For example, you might ask, have you noticed any changes in your drinking or other habits since these symptoms started? Sometimes what looks like anxiety or depression on the surface is tied to an underlying substance use disorder, and missing that can delay meaningful treatment. Another question might be, do you feel that these experiences connect to anything from your past, like a difficult relationship or a traumatic event? And this can help uncover a history of PTSD or unresolved trauma that might be contributing to the picture, or even a personality disorder. So take this scenario. A client says that they've been feeling anxious and struggling to sleep. If you ask about their coping strategies, they might reveal that they drink a bottle of wine every night to help them wind down. And this might indicate an undiagnosed alcohol use disorder alongside generalized anxiety disorder. Or consider a client who talks about difficulty concentrating and feeling restless. By asking when these symptoms began, they tell you that it started during a stressful time at work, pointing more towards generalized anxiety disorder than ADHD, which would typically have been present since childhood. You might even want to consider something like an adjustment disorder too, if it's something short term that will pass over time and they just need help getting over that hump. Asking these kinds of questions isn't just about ticking boxes on a diagnostic checklist. It's about showing curiosity and care for the client's unique experience, creating a space where they feel seen and heard. And this thoughtful approach lays the groundwork for accurate diagnosis and meaningful treatment plans that truly address what the client needs. So let's walk through two case examples to see how differential diagnosis works in practice. And these cases will just highlight how overlapping symptoms can point to very different disorders and how asking the right questions can clarify diagnosis. So, case one, imagine a client who reports feeling constantly fatigued, struggling to focus, and being irritable. On the surface, these symptoms might suggest major depressive disorder. However, as you dig deeper, you'll learn that the client has recurring nightmares and avoids specific places like crowded areas or intersections due to a recent car accident. These are key indicators of trauma related symptoms and point towards post traumatic stress disorder. And while fatigue and difficulty concentrating occur in both PTSD and major depressive disorder, the avoidance behavior, hyperarousal manifesting as irritability, and trauma related triggers differentiate it to be PTSD. Asking questions like, do your feelings of fatigue and irritability seem tied to certain memories or situations can help uncover the root cause of these symptoms. For this one, we would consider PTSD for them. Case number two, we have an adult client who struggles with impulsivity and attention difficulties. At first glance, this might sound like attention deficit hyperactivity disorder or ADHD. However, upon further exploration, the client describes periods of excessive energy, racing thoughts, and reckless behaviors, followed by weeks of feeling drained and unmotivated. This pattern is consistent with bipolar disorder, particularly when impulsivity occurs during manic or hypomanic episodes. Differentiating ADHD from bipolar disorder requires asking questions like, have there been times when you felt so energized that you didn't need much sleep or made risky decisions you later regretted? Unlike ADHD, where impulsivity and inattention are persistent across time and context, bipolar symptoms fluctuate with mood episodes. So, for each case, the key is to gather detailed information about symptom onset, duration, and context. So, in case one, identifying the link between symptoms and a traumatic event like the car accident points towards PTSD. In case two, noting mood fluctuations and episodic patterns, highs and lows, helps distinguish bipolar from ADHD, which lacks those mood driven cycles. When it comes to differential diagnosis, the process can feel overwhelming, especially when symptoms overlap across multiple conditions. However, counselors can approach it systematically by using evidence based tools, considering the client's unique context, and collaborating with other professionals. So, here's some practical tips to guide you. We want to use structured clinical interviews and tools. So, the assessments you likely learned about in your master's program, like the PHQ-9 for depression, the GAD-7 for anxiety, CAPS-5 for PTSD, they're invaluable for gathering objective data. These tools were developed through rigorous research to help identify specific symptoms and guide diagnostic decisions. For example, if a client presents with general anxiety symptoms, the GAD-7 can help quantify the severity and identify patterns. Similarly, if trauma is suspected, the CAPS-5 provides a structured way to explore PTSD criteria, ensuring no symptom is overlooked. Don't hesitate to revisit these tools. They can clarify what might feel confusing during intake or ongoing assessment. And we want to consider cultural sensitivity and developmental context. Diagnosis isn't just about checking boxes in the DSM, it requires an understanding of the client's cultural background and developmental age. Symptoms that seem pathological in one context may be completely normal in another. So, for example, certain cultural practices or beliefs might resemble delusions but are considered typical within that cultural framework. Similarly, developmental considerations matter. Impulsivity in a 5-year-old is very different than impulsivity in a 30-year-old. Asking open ended questions about clients' upbringing, values, and environments can provide essential context to interpret symptoms accurately. And we want to collaborate with the multidisciplinary teams. Counselors don't work in a vacuum. You're not on an island. You're not alone. And diagnostic clarity often requires input from other professionals. Collaboration with psychiatrists, medical doctors, or occupational therapists can provide a more comprehensive view of the client's condition. For instance, medical conditions like thyroid disorders or medication side effects can mimic or exacerbate mental health symptoms. The psychiatrist might identify psychotropic medication needs where a medical doctor can rule out physical health causes for fatigue or concentration issues. Multidisciplinary collaboration ensures no stone is left unturned and the client gets holistic care. And always, we want to stay curious and avoid rushing to conclusions. It's easy to feel pressured to diagnose quickly, but differential diagnosis is a process. Staying curious and asking follow up questions can reveal details that change the clinical picture entirely. For example, a client presenting with symptoms of depression might over time disclose a history of trauma or substance use, shifting the diagnostic focus. Taking the time to gather a full history and revisiting diagnoses as new information emerges demonstrates both clinical skill and care. Differential diagnosis is like being a detective. It's about piecing together the clues of overlapping symptoms to uncover the most accurate and helpful understanding of what's going on. Just like deciding if an illness is the cold, the flu, COVID, it guides how we treat it. Understanding whether a client's fatigue, impulsivity, or social withdrawal stems from a mood disorder, a personality disorder, trauma, substance use, all of that shapes the care that we provide. Getting the diagnosis right matters because it leads to the right tools, the right treatment, and the right support for our clients. As counselors, staying curious and reflective in your clinical practices is key. Keep exploring, keep asking questions, and considering the whole picture of your client's experiences. If this video sparked new ideas or questions, I would love to hear from you. Share your thoughts, ask questions, or suggest topics that you'd like to learn about more in the comments. Let's keep this conversation going and continue growing together in our understanding and practice. Thanks.